So part of the key strengths are the working relationship, as I said, with the partners in the multidisciplinary format. Second key strength is the ability to go from the bench, working with cancer researchers in the Lineberger Comprehensive Cancer Center, all the way to clinical trials through the Clinical Protocol Office. We've done this in a number of different diseases that are not very common in the community, but are common enough that we get referred in those types of diseases. And I think the last and probably more comprehensive strength moving forward is the ability to understand at a very molecular level what's driving the types of diseases that we treat. So these diseases are, one, sometimes very complex. For instance, acute leukemia is probably, outside of an intensive care unit setting, the most complexly treated. And the cure rates right now are not 100%. So we understand for these individuals that we have perhaps better treatments available, or we need to look at the ability to find better treatments. And so almost everybody's encouraged to enter into a clinical trial. For some of the other diseases, such as lymphoma or myeloma, we tend to get a large number of patients referred in after they've failed. In most instances where the cure rates aren't close to 100%, we can always learn something about the biology of the disease, about how the patient tolerates therapy, about whether or not this is the best treatment for them. And the best way to do that is in a comprehensive manner where you enroll in a clinical trial where the treatment's straightforward but well elaborated and where you can understand the risks and benefits. And so often as you see these referrals increase over time, you realize that there's an unmet need in the community for specific therapies for specific types of disease, and that'll inform the clinical trial portfolio that we offer. There's been actually a few recent breakthroughs for treatment for our group of patients. Probably the disease that's had the best track record for recent breakthrough drugs is multiple myeloma. So this is a disease that 10, 15 years ago was uniformly fatal, with an average survival of, at best, probably 3 to 4 years without transplant, and perhaps a little bit longer with transplant. The average survival now has doubled to almost tripled. I think that there's still a fair amount of self-interest in that we often have treatments available at the clinical trial arena that you can't get locally, but are quite promising. For instance, imatinib, before it was a FDA-approved drug for the treatment of CML, we were one of the 4 or 5 centers in the country that can enroll patients on those trials. So that was clearly in the patient's best interest to do that. And then altruistic, because we can always learn things that may not, unfortunately, help that specific individual, but will help individuals later on. Well, I think it's an incredibly exciting time for all of us right now. The genetics of cancer has kind of overwhelmed us in terms of what we didn't know and what we're learning. And so over the last probably 10 years, there's been an explosion of information about what mutations drive leukemia, what groups do better with treatment, what groups do poorer with treatment, the ability to identify specific gene mutations and specific therapies for those gene mutations has been completely new. When I was a fellow, the most difficult leukemia to treat was a type called acute promyelocytic leukemia. With the development of a pill called transretinoic acid, we've now taken the hardest to treat disease and made it the easiest to treat disease. So again, now 3/4, 4/5 of the patients with that disease are cured with therapy, and the ones who aren't are often cured with arsenic trioxide as second therapy, which is new. So I think most of us believe that's the paradigm moving forward, understanding the genetics of the disease. Once you understand the genetics of the disease, then working on discovering or evaluating compounds that specifically target those genetic abnormalities as a way to treat in a less toxic, more rational manner. I have kids who, we transplanted in their teens who are off in college or get married. I have individuals who we treated in their 20s who often have families and new jobs, and that's probably the most exciting part is, seeing the individuals that you take care of go off and live their lives.